Morning and welcome to Deuk Spine Institute live stream. Our first surgery for today will be live streaming. Is a patient who traveled here from Puerto Rico. He has some damaged discs in his neck. He has 3 to be exact, and they are causing pain, unbearable pain down his left arm. He has radiculopathy in his left arm, and it's keeping him up at night. He can't sleep. He has to hang his left arm over the bed to try to get some relief. So basically this is a pinched nerve situation going on in his neck. Is this the right size? I don't know. I don't think it is. All right. If you have questions during our live stream, type them up. Henry will ask me. I will answer them. This surgery will take about an hour and a half. We're fixing 3 discs, number 3-4, number 5-6, number 6-7. 3-4, 5-6, 6-7. So he has herniations at 3 discs with degenerative disc disease, herniated discs, spinal stenosis in the cervical region, with pinched nerves. He's asleep. We have him under general anesthesia. He has a tube down his throat. He's completely relaxed. And I'm going to start with the bottom discs, fix those 2 first, and then go up to number 3-4. If you have questions, type them up. In the meantime, Henry, let's show the audience the 30 different causes of neck pain. 2, 3, I'm Dr. Deuk, CEO and founder of the Deuk Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Deuk plasma rhizotomy is the best treatment in the world available for painful facet joints. Deuk laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. All right, welcome back. As you can see, there are 30 very specific causes of neck pain. And this patient's symptoms are not so much neck pain, they're more arm symptoms, down his left arm. So we're going to fix any neck pain issues as well, but mostly his left arm. I've already made a 4mm incision. I'm going to remove my needle. I did a discogram, which you guys can see dye within the disc. The disc injuries in the neck account for 90% of the primary cause of pain in the neck. Disc injuries, okay? Disc injuries. Shot. So if somebody has neck pain, 90% of the time you'd be right to say, without knowing anything else, ever seeing an MRI or doing an exam, 90% of the time you'd be right to say their pain is coming from a disc injury. Let's go, AP. We're going to use the X-ray machine to navigate and to localize. We've lost 1 drop of blood this whole surgery so far, 1 drop of blood. And we're already down to the spine. Okay, that looks pretty good. I'm a little bit on the left side of center. I can correct that and come back. What I'm going to do is shot. Let's get the shoulder pulled a little bit. A little bit of inline. That looks really good. And I'm going to take this guide wire out, shot. And that looks good. And I'm going to correct a little bit, just a tiny bit over to his right, shot. Looks good. Shot. AP. All right. So far, so good. We've lost 1 drop of blood. We're entering the C6-7 disc, the hardest disc to get to. It looks good. We're going to head to the back of the disc where the herniation and tear are. Any questions, feel free to ask.
We have a question coming from Killa Penguin on YouTube.
All right, I'd be happy to take your question.
Asking Dr. Deuk, can you have a
Little
quote,
inline.
toxic annular tear even with only a 3 millimeter disc bulge? Is this able to be confirmed via discogram? I have bilateral nerve pain into my legs when I sit. No one can figure it out.
Well, my friend, I can figure it out for you. If you hop onto a Zoom call with me, you don't even need a discogram. I will do it on the Zoom call. All right, are we doing a little inline? Good. All right, I want to just get back a smidgen. That looks really good. I will figure out where your pain's coming from on literally a 10-minute Zoom call. I'll tell you where it's coming from, and I'll tell you how to fix it. All you got to do is do the MRI review. Henry, put a link to our free MRI review. It doesn't cost you any money. It's very simple. Upload your DICOM images or send us your CD, and we'll schedule you for a 10-minute session. But to answer your question, the discogram will not answer your question about your leg symptoms at all. I will be able to tell you, and yes, definitely a 3 millimeter disc bulge can definitely cause back pain and leg symptoms. Okay, any disc bulge, whether it's a millimeter, 2 millimeter, 3 millimeter, it doesn't matter. It's an indication that there's a tear in the back of your disc. Any disc bulge is an indication your disc is damaged. Specifically that there's a tear in the back of your disc. And it has to be a tear and a bulge in the back of the disc, not in the front, not on the side. It must be in the back. We're just advancing our tube down the shaft through the disc space to the tip of the dilator. When I get done with this movement here, my surgical tube, my endoscopic tube, will be at the back of the disc. Don't try this at home. Listen, I'm going to tell you guys, there's a rise in the number of doctors out there advertising that they do laser spine surgery when they don't. And what they do is people will find them on the internet through their laser spine surgery webpage or whatever, and they will tell people they do laser spine surgery. When you actually contact them and say, hey, I want to come get laser spine surgery, they tell you, oh, yes, we do laser spine surgery, but you're not a candidate. You have a problem that isn't fixable with laser spine surgery. They lie to the people. They lie to the patient, and then get them to do a fusion or artificial disc or laminectomy. Avoid these scams. Go with a company that has a reputation like Deuk Spine Institute. If you ask me, Dr. Deuk, who else does laser spine surgery in America? Nobody. We're the only ones. Who else does laser spine surgery in Europe? Nobody. Because nobody else, I've not trained any other surgeon yet on how to do this technique. Now, there are surgeons who watch these live streams and may try to do it in their countries of, say, India or China or who knows where, but they have not been trained by me. And I'm the inventor of this technique. So until they come and train with me in a fellowship, I would not trust them to do your laser spine surgery, okay? We are the pioneers of laser spine surgery here at Deuk Spine. We do more laser spine surgery than anyone else in the world that I know of, okay? So, and we do it successfully, very successfully. That's why people travel from all over the world. Today, we have 5 surgeries. We have patients from, this patient is Puerto Rico, which is outside the United States, as you know, but it's part of the U.S. territory, Puerto Rico. We have patients from today from Kuwait, from Kentucky, from South Africa. We have a surgeon here from South Africa today who will be getting thoracic disc repair later today. That would be our 3rd case, correct? Or 2nd or 3rd?
Yeah,
the 3rd case. So we have international patients that come to Deuk Spine because we are the best in the world. Nobody else offers this treatment, not even in the most developed countries of the world. That's why people travel to Deuk Spine. They are not, these are smart people. Why are they smart? Because they're not going to take a chance with some no-name company. They're going to go with the leaders in endoscopic laser-assisted surgery. That's us, Deuk Spine Institute. We're the best in the world. We're the first in the world. And we're the only ones doing the most successful surgeries on discs and other areas of pain. So I'm not bragging, I'm just telling you the God's honest truth. And I fear for patients that go elsewhere. I fear for them because I know what these other doctors do. They hurt people. They hurt them very badly. I've seen so many. I do telemeds every week, and I see, thousands of patients a year on telemeds from all over the world, and I see their MRIs, their x-rays, their CAT scans after they've had surgery with other doctors. And these are supposed to be great surgeons in San Francisco or wherever, Texas. These are supposed to be top spine surgeons. And these people are having horrible, horrible surgery with horrible complications. Even when I was doing fusions, I didn't have those complications. So the surgeons are doing a very bad job, in my opinion, treating patients. They're doing a worse job of diagnosing patients. And my fear is for the patients. I worry about the patients suffering because of these surgeons' horrible treatments that they're doing. Technically, very bad surgery. Putting in the wrong size cages, damaging the spine and the areas around the spine, the muscles, the ligaments, the tendons being disrupted by the surgery, being totally devastated, destroyed by the surgeon. Everything okay?
Yes, sir.
All right, so anyway, we've shown you the 30 different causes of neck pain, chronic neck pain. The disc is responsible for 90%. This patient has 4 damaged discs, but 3 of them are causing his symptoms. The 4th one is not. Therefore, I did not recommend treatment on the 4th one. He's from Puerto Rico. He traveled to Deuk Spine in the United States just for surgery. And he's here with his lovely girlfriend. I've had an opportunity to get to know them. He's a very nice man. And me personally, I love Puerto Rico. I think it's an amazing place to visit. I've been there myself. As a matter of fact, we used to have our neurosurgery meetings probably about every 2 or 3 years. This is like 20 years ago. We used to have the meetings in Puerto Rico. I don't know why we stopped, but we should go back to it because I loved Puerto Rico. It's such a beautiful place. The people are wonderful from Puerto Rico, and it would help the economy. But the American Association of Neurological Surgeon meeting was there. The Congress of Neurosurgeons, the Southern Neurosurgeons meeting was there in Puerto Rico many years ago, and I wish we could go back again. They're always having these meetings in these boring places like Los Angeles. There's nothing in Los Angeles but smog and traffic, right? Of course, I know that because I'm from Los Angeles. I did my medical training at USC in Los Angeles, one of the top med schools in the country and the world, and I was valedictorian of my medical school class. I was number 1. But I have no interest in going back to Los Angeles unless I was going to run some experiment on the effects of smog and traffic on people's personalities. All right, this is all scar tissue here at the back of the disc. And when we do this procedure, we don't just fix the right side or the left side. I want you to look here. You guys see that right there? That's the herniation. and it's scarred down behind the disc, and I'm about to release it with the laser. That's why the laser is so important. It cannot be done, this surgery cannot be done properly without the laser. Here it comes. You guys see pieces of it coming out. There's a big piece of herniation right there. I'm releasing it. It's stuck down. This is what other doctors cannot do with their surgery, but we can do it with our procedure. We're releasing the herniation off of the nerve root and spinal cord. Whoa, there it is. You guys see it come out?
Yes, we did.
It came out so fast. There it is, right there in the tube. And the fluid coming through the tube, the irrigation, pushes it from the back of the disc where the herniation was up to the outside of the tube, so it comes out of the patient's body. So it's quite an amazing system. Look at that. That's the defect where the herniation was pushing on the nerve and the spinal cord, right there. And there's still a little bit left. So we're zapping it away. Now, some of you may say, wow, Dr. Deuk, how small is that laser fiber? It looks small. You're right. That fiber is 1/2 a millimeter across in diameter. That's 0.45 millimeters. That's how precise the instrument is. And by using the endoscope, like I'm doing right now, I can actually use the laser to remove 1/20th of a millimeter. 1/20th. So you take a millimeter, which is the space between your fingers where you can barely see light. Oh, there's another herniation. There's another herniation. Look at all these pieces coming out. Okay, all we're doing is removing the herniation and cleaning the tear where they came out. This is the tear right here. I'm cleaning it so that it will heal when I'm done. It will heal itself. So this laser can actually, if you take the space between your fingers, which is 1 millimeter, just enough to have light come through, and you divide it into 20 parts. Okay, you imagine how small that is. That's what I'm able to remove right here, 1/20th of a millimeter. No other surgical instrument or surgeon in the world doing ACDF, artificial disc, they don't have that kind of precision, ever. There is no other tool in medicine, and this is in my opinion, that can be as precise as the endoscope and this laser fiber with the Homium YAG laser, okay? That's how precise it is. We're looking across the entire disc. I don't see any more herniation yet. We're gonna go look out the left foramen. Remember, this is 6-7. We still have 2 more discs we have to fix besides this. So there's bone spurs right there. I just zapped it away. Again, the laser is the most precise tool, in my opinion, in medicine. And people, doctors that don't use the laser, they lie to people and say, oh, it's dangerous. No, it's not dangerous. It's dangerous if you're not trained to use it. I've been trained to use the laser many years ago. 20 years ago, I took my training. And it's also dangerous to do surgery. It's dangerous to do neurosurgery if you're not properly trained. Hey, I need a little help. Can you push here? So I'm trying to get out his, oh yeah, that's much better. Thank you, Luis. There's a bone spur right there. There's still some herniation right there. We're going to get this. This is pushing on his nerve, his C7 nerve root in the foramen. I'm going to have to pull back and try to go a little bit more. You helping me, Luis?
Yes, sir.
You okay?
Yeah.
I don't want to hurt your fingers. That's herniation right against the nerve root right there. You guys see that? Look at how precise the laser is. We have never had a complication from this surgery, ever. In 20 years of doing it, we've done 2,700, and this is number 21, laser surgeries, 2,721. We have 21 here. We have 22 next, then 23. And then, yeah, we're doing 2,723 by the end of the day today. Oh, look at that herniation coming out of the foramen. Now, I will tell you, there's a lot of surgeons who say they do laser surgery, but they don't. Don't believe their lies. If you go to them and they say, oh, we're not going to do laser spine surgery because you need a fusion or a discectomy or an artificial disc, they're lying to you. They don't do a laser surgery, okay? And I will tell you, one of them, unfortunately, is my own brother. His company over in Tampa is now advertising that they do laser spine surgery. Why? Because he has the same last name. And they get a lot of patients calling saying, hey, is this Dr. Deuk and you do laser surgery? And they've been telling everybody for years, no, we don't. We do fusions, artificial disc, laminectomy. And now they're advertising that they do laser surgery when they actually don't. So I'm just telling you, even lots of doctors are lying and saying they do it. This is the future of spine surgery, this laser spine surgery you're watching right now, Deuk laser disc repair. We do a very specific type of laser spine surgery, but I see lots of websites now out there advertising that they do laser spine surgery when they actually don't. And I know my brother doesn't do it. They're just doing that to capture patients. But I'm going to be honest with you, they're not the only ones doing it. And it's not him, it's more his partner. I won't say who it is, but I think it's dishonest. And I don't believe in dishonesty. I believe in honesty. I don't think doctors should make a living by being dishonest to people. They should make a living by being honest to people about what's really happening. So that said, be aware, there's a lot of doctors out there saying they do laser spine surgery when they don't, okay? That was a bone spur I just took away. There's really no more herniation that I can see in the foramen. I'm just about done, and I'm gonna move up to C5-6. Okay, I'm going to look across one more time at C6-7, and then we're going to move to 5-6. Okay, so any questions?
Yes, we have a couple questions coming from AAKK on YouTube.
All right, welcome back.
Asking, I know we're in the cervical spine, but is it possible to perform the DLDR on levels that have been fused if the disc has not been resected, like operating DLDR on L3-4 on an L2 to L5 prior fusion?
Yes. That is a great question. A great question. So I'm going to repeat the question so everybody hears it. Dr. Deuk, can you do your Deuk laser disc repair on a disc that already has been fused if the surgeon did not take the disc out completely and there's still disc material back there at the back of the disc? The answer is 100% yes, we can. We've done it before and we've done it successfully. I've seen patients that had fusions where the surgeon did not remove all the disc in the disc space, and when they put, you don't need to be so loud. And when they went in and they left the disc material in the disc space, okay, they put the cage in and that pushed the disc material back against the nerves. And we're able to go in from the side behind the cage and remove the disc material that they did not take out. Yes, we've done that before and we've done it very, very successfully. But I have to see the films first before I do that. I have to see the films, your MRI, your CAT scan. I have to make sure that I can actually help you before I recommend surgery. I don't recommend surgery to anybody that I don't believe I can help them. I have to have at least an 80% chance of having a successful procedure with me for me to recommend treatment. I don't recommend treatment for, well, there's a 50-50 chance we'll help you. I don't do that. I would never do that to a patient. It's not ethical in my opinion. It's not moral. You don't operate on someone's spine with a 50-50 chance you'll help them. Okay? That's what other doctors do. If you ask your surgeon, what's the chance you're going to cure my pain? They'll tell you 50-50. That's nonsense. They shouldn't be operating on you. Not for 50-50. It should be at least 80 in my opinion. That's mine. But most doctors do not have an 80% success rate. They have maybe a 25 to 50% success. So that's why they tell patients 50% chance will help you. Okay? And there's all kinds of complications that happen with their surgeries, not with ours. Why is the suction weak?
Suckers, please.
All right. Any questions?
Yes, we have a few more questions asking, coming from AAKK once more on YouTube, asking, I saw now that you have a fellowship opportunity. Would this be open to ACGME pain trained fellows, PMR or anesthesia backgrounds, and pain fellowship trained?
Yeah, it's a great question. So what I'm being asked is, does Deuk Spine Institute offer fellowship training to pain management doctors that are ACGME, trained from an ACGME accredited facility? So the answer is yes, we do have a fellowship, but I am currently not training anyone yet, and not with this procedure. We used to do pain management fellowships with Dr. Patel, but we found that the doctors would train with us and then they would come out and compete with us. They would just stay here and open an office and see patients and take our patients away from us. So we decided this just wasn't worth it. There was no real benefit to training doctors in our techniques because they just try to steal our business. So, we're not busy enough to really share yet what we have. If we were busier, then we would be training more doctors. And yes, I would open this up to ACGME accredited pain management doctors, but not just any pain management doctor. I would have to vet them, and I would have to see, I'd have to basically be comfortable that they're a high quality doctor who is extremely capable, and then I would consider training them. So the answer is yes, I would, but not right now. All right, we're going to move out of 6-7 disc because we've just finished decompressing the nerve root. We're going to move up to 5-6. Now, 5-6, I think, is the worst disc. I think it's causing the most symptoms. Shot. I've got to come out of this disc and slide along the front of the spine up to 5-6 and then enter that disc. This is, in my opinion, the hardest part of the entire surgery. I've got to feel with my fingers. I'm right about out of the disc. I'm sitting right on the tip of the mountain, so to speak. And we're almost, all right, we're out. Shot. So I'm up against the front of this next vertebral body, C6. I have to move up to the 5-6 disc. Shot. But I got to stay in the middle. Yep, I'm a little bit to the left. I'm going to move back to the center. And I have to stay right along what's called the ALL, anterior longitudinal ligament. Shot, which is located, yep, perfect, which is located between the longus colli muscles, and there's a sympathetic trunk within the longus colli muscle on each side. You want to avoid injuring that sympathetic trunk. You don't want to damage the longus colli muscles, so you want to stay in the midline. All right, we're up at shot 5-6. Right about there. Feel the lip going over it. Shot. All right, so I'm sitting on front of the disc at 5-6, which is my next target. I want to check AP and lateral, make sure I'm dead center. Shot. Better picture. Better picture. All right, shot. All right, that looks shot. That looks good. Lateral. I'm happy with my AP and my lateral. I'm going to enter the disc. Shot. Perfect. I don't need inline. All right, we're inside the disc. Shot. All right, now I'm going to do my discogram. Put my dye. Speaking of which, we have one patient today who is allergic to iodine. Shot. Where's Hector? Do we know that, guys? I want to say it is our thoracic, maybe? Shot? Shot? All right, I can't get any dye out. I'm going to try to go a little further back and shot. So the reason I can't get my dye out is that there's a lot of scar tissue inside this disc. Why? Because the herniation's been here for so long. It's created inflammation. It's created scarring. And the scarring is happening inside the disc. So that's really hard to push the dye into the disc that's scarred. It's a degenerated disc. What? Any questions? Sean? All right, I think I got a little bit. Yeah. Got a little out, but it's not real. There's the tear. You guys see the tear? Shot? There it is. Finally, we got the tear to fill with dye right there. Yep. You guys see the tear in the back of the disc. That's what we're here to clean up, is that tear. is called an annular debridement. Shot. Again, this disc is just so full of scar tissue. Shot. Berndes, I think a little inline traction could be helpful at this point. Ready? Yep. All right, we're inside the tear. Perfect. I'm going to place my tube. By the way, for those of you who've never seen the surgery, this is endoscopic surgery. It's done with a tube that's only 4 millimeters. You guys see that? 4 millimeters. All these other surgeons are doing open, big surgeries, cutting your neck open, slicing the esophagus, the muscles, destroying so much inside your neck. That's why you can't swallow after ACDF or artificial disc. All the destruction of your body. And that's permanent destruction. With our laser, nobody has that problem. That's why we're doing no trauma to your body, just the skin. We make an incision, that's the only trauma. Shot? All right, we got to watch the tip of that dilator very carefully as we advance 1 millimeter at a time. We don't want that tip of the dilator moving in. That could be very bad. So I'm just taking my time, doing this right. Luis is helping me by watching that dilator. I'm watching the tube as well. You can see the tube moving through the disc to the tip of the dilator. Now, if you don't have the dilator, the tube would just biopsy the disc. We don't want a biopsy. We don't want a hole punch. We want to go to the end without taking the disc out, and we want to remove just the herniation. All right, a little inline. Give me some more inline. We're almost there. 2 more millimeters. You guys are doing a great job. That's it. We're done. Okay? This is about millimeter precision and less than millimeters, sub-millimeter. See the incision? No bleeding. Our surgery has, if you're considering anterior cervical discectomy fusion, laminectomy, artificial disc, foraminotomy, those are alternative treatments. They all suck. They don't give good results at all with respect to pain, with respect to decompression, when most doctors do them, okay? When I do them, they give great results, but they're far more invasive, a lot of damage inside the neck. Even in my patients, I have to make a big incision and cut through muscles, which you don't want to do. This is a far better surgery. This is the future of spine surgery for the world. And it's being done at Deuk Spine. We pioneered it, I pioneered it, and I peer-reviewed and published it. It's all FDA approved, and people come from all over the world here for this treatment because we're the only ones doing it. All right. Any other questions? Let's show the audience, before I take any questions, how a disc injury can be so painful. Why are disc injuries painful in the neck?
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
All right, welcome back. You can see from our animation that the way the disc injury causes neck pain is, by the way, this is all bone spur right here. You see this ridge? That's a bone spur. And I'm removing it with the laser. Look at how precise the laser is. Folks, I love it when people say, Dr. Deuk, you can do laser, but it can't remove bone spur, right? No, of course it can remove bone spur. They use these lasers to cut through kidney stones, through calcified lesions in the body. This is a medical laser. It's manufactured in Israel. My opinion, the best laser in the world for medicine, for medical use, like mine. Okay, Israel, best laser in the world. And it's perfect. It does the job so well. Look at all the scar tissue here. This is all scar tissue. This should not be here. This is here because his body is trying to heal the herniation, the tear. Okay, that's why it's here. So you saw in the video how the disc itself causes pain. It's through inflammation happening in the back of the disc. Now, when I first came in on this disc, this is 5-6. When I first came in, there was no movement of the bone. You guys see the bones moving down there? They're moving about a degree. But there was no movement because everything was scarred together. So our surgery actually gives people back movement. You can see the movement now, right? This is a bone spur right here, but it's not pushing on the spinal cord. I'm not going to take it away because even though I can do it safely, there's a risk to the spinal cord and it's no benefit. No benefit. I don't do moves that are no benefit to the patient. They must be a benefit to the patient. Otherwise, I don't do it. Okay? That's what a good surgeon does. We don't do things that don't benefit the patient. We do things that benefit the patient. That makes you a good surgeon. Okay? Everything we do as doctors should benefit the patient. Unfortunately, in the United States and other parts of the world, medicine has changed to where doctors do things that benefit them and the hospital and the companies that manufacture metal implants or plastic implants, such as cages that go in your neck or artificial discs. But you see, this surgery, we use no cages, no metal, no artificial discs, nothing. It's natural. We're just cleaning up the herniation, the tear. Like right here is herniation right there. You see that? It was that piece that just popped out was pushing right on the nerve. All this stuff here is, oh, look at that. Oh yeah, that was pushing on his nerve root. And by the way, this is on his right side, right here. It's too big, I can't even take it out. I have to try with the grabber, we'll see. But that was on his right side. He was gonna lose function in the right arm. So his main symptoms are left, but he was gonna have right arm problems too if he didn't get this surgery done. I didn't get it. I have to go down and grab again. There it is. Here. You guys see that?
Yes, we do.
Now, it looked huge, didn't it? It looked huge, but it's only 3 millimeters. Okay? So how is it that a 3 millimeter herniation can cause symptoms? The answer is it cannot. You need 10 or 15 3 millimeter herniations. And when we talk about a herniated disc, we're talking about 15, 20, 30, 40 pieces of herniation adding up, compressing. It's not one little piece, it's many pieces. Like, I need the laser on. Where did she go? All right. Well, I pushed the pedal, it didn't go. All right, sorry about that. This is the foramen where we were just looking and we got all the pieces of herniation, but we got some more left still right there. This is where the nerve is being pinched, right there. Oh, look at that. All that is garbage, shouldn't be there. Calcium is the gold stuff. We call it dystrophic calcification. It's found within damaged tissues in your body. It's starting to calcify. When they talk about a calcified disc, that's what they're talking about. The more calcium there is, the more calcification there is, the harder the disc becomes. But there's the foramen, there's the nerve root. You guys are looking at the nerve root. I'll show it to you in just a second. This is at C5-6. This is the right side, the right foramen, 5-6. So that has to be the C6 nerve root right there. You guys see it right there? I'm touching it right now with the laser. Okay? I'm bouncing on the C6 nerve root. All right, but I'm not going to damage it. I'm just touching it. Touching it is okay. As long as you're a neurosurgeon, you get to touch nerves. That's what we do. But I've removed the herniation. Remember there was a piece of herniation right there pushing on the nerve? It's gone. All right, now I'm going to go look at the other side, the left side. We're going to go swing over to the left side. There's the left side. I'm going to have to pull my tube back a little bit. And we're going to go out that foramen and make sure that there's nothing pushing on the nerve. So, a lot of arthritis, I'm going to advance my laser fiber a little bit, another couple of millimeters. Any questions?
Yes, we have a couple questions. Next one from Lanu on YouTube.
Hi, Lanu, welcome.
Asking, are you guys doing surgeries during long holiday weekends?
We will do surgery any day except for Christmas Eve maybe. I'll do surgery Christmas Eve. The reason is, here's why. People living in pain should not live in pain. They should not have to suffer, not a single day. In my opinion, oh, look at that. You guys saw that? Piece of herniation there in the foramen? I'm the owner of the company, the founder, so my philosophies are what people here live by. They're supposed to. And if they don't, they get in trouble. But basically, my feeling is I want to fix people any day, any time that they want to be fixed. Okay? We just have to come up with a schedule, figure out, get everybody here, my staff. I can't do this alone. I need my team. The old saying, no man is an island, is so true. No man is an island. Okay, I can't do it on my own. I must have a team, and my team has to be the right team. It has to be trained, the right people, the right equipment. Everything has to be done properly. I won't do surgery half-assed. Okay? Why? Because I know what happens when you do surgery, cutting corners, without the right people, without the right equipment, without the right everything. You can hurt the patient. And I don't want to hurt the patient. I want the patient to have the best result. To get the best result, you must use the best of everything. The best equipment, the best drugs, the best people, the best everything. And that's what Deuk Spine is. We are the best of everything. For this surgery, we have the very best. We cut no corners. So, I have to have everything here, but I would operate any day of the year. It doesn't really matter to me. I would operate on my birthday. I've operated on my birthday many times. I don't care about my birthday. I care about fixing people. And if I have an opportunity to fix somebody on my birthday, I'll do it. Right? Even Christmas Day, I would operate. It doesn't matter to me. There is no day of the year that I would not jump at the opportunity to fix someone's back or neck. If I can do it, I will do it. That's how committed I am to what I do. I love what I do. I think my team loves what they do. And we love to help people get out of pain. And pain is misery. Pain is suffering. Pain is the worst suffering humans can endure on earth is pain. Okay? Maybe, even if you have your breath taken away, if you're waterboarded, you have pain. The pain is the not ability to breathe. Okay? So whatever it is, pain is the worst thing we suffer with. Whether it's emotional pain, psychological pain, physical pain, it doesn't matter. It's pain. And if I can take someone's pain away and sacrifice my Christmas, I would do it. I would be there. So if somebody said to me, I want to be fixed and I can't do it any other day but Christmas, I would do it on Christmas. That makes sense? That's how dedicated I am to what I do. All right. Wow. This has been a lot of scar tissue and calcium. You guys are seeing it right there with me. You see everything I see, by the way. The only thing is you can't feel what I feel, but you can see what I see, and there's nothing to smell. So this is a visual and tactile experience for the surgeon. And yeah, any other questions? If not,
yes.
Let's show the audience how the Deuk laser disc repair cures people's pain.
We do have a question. Do we want to continue with the video first?
Let's do the video first, then we'll come back for the question, because we're almost done with this disc, and then we're going to move up to C3-C4, and we'll be finished.
Copy that.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4 mm skin incision is made. A A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. Look at this piece that I just took out. It's about, 6 millimeters long. It's like a little asteroid. Okay? Doesn't look like much, but again, when you add them all up inside the back of the disc, pressing on the nerves, the combined volume of herniation is what causes the symptoms, okay, with pressure. Now, inflammation is different, right? So that's where I took it from, right there. So I didn't even get the whole piece of herniation. I got half of it. Let's go get the other half if we can. It's too big. So I grabbed it, and I could feel it kind of break. It was so big it wouldn't fit out of this 4 millimeter tube. I'm going to have to go in and use the laser to break it smaller. It's too big. So we're going to go in there and get this herniation and break it up into smaller pieces. All right. There it is. You guys see it?
Yes, we do.
I got to cut it in half. Bivalve. All right. So we showed the audience the 30 causes of neck pain. We showed the audience how DLDR works. And now we're showing the audience the last video is going to be DLDR versus other treatments, correct?
Correct, but we do have a couple questions.
Let's take your questions.
These are coming. This one's coming from AAKK once more on YouTube. Oh, we just got a lot of questions. This first question from AA asking, thank you, Dr. Deuk, for being wonderful. With this multi-level DLDR in the cervical spine, what is your best recommendations to prevent re-herniation post-surgery? Do you advise C-collar, soft collar?
Yeah, great question. So the most important thing, so let's address AAKK's question. I'm going to repeat it so everybody understands it. AAKK asked, Dr. Deuk, you're fixing 3 discs in the patient's neck. Now, there's a risk, and he's right, or she's right. I don't know if AAKK is a man or woman, but they are correct in that patients that have this surgery, the Deuk laser disc repair, can have what's called re-herniation. Now, re-herniation is when the patient gets another piece of this right here, what we're looking at, the herniation, squeezes out to the back of the disc against the nerves, or spinal cord in this case, before the disc is sealed on its own. Now, it takes the human body about 6 to 9 months, maybe 12 months in some people, to seal this area up. They will seal it. This area will seal. Your body will seal it, but it takes 6 to 12 months to do that. The soonest would be 6. I think the latest would be 12. Okay? So this whole area will seal. Your body will literally make a wall out of collagen, which is basically scar tissue. It's the same thing that the wall is made up originally. The wall of the disc is made of collagen. So the body will seal it with collagen. This is a bone spur. And it takes about, let's just say 9 months for that to happen. Now, during that 9 months, the patient can re-herniate. They can squeeze out more material that's in the disc part, the nuclear part. They can push out another piece. And that's called a re-herniation. And that does happen with our surgery. That is the only downside to our surgery. And that's true for any surgery, by the way. It's not unique to DLDR. So if you have a discectomy done, you can have a re-herniation. The re-herniation rate is around 50% for discectomy. With Deuk laser disc repair, it's 1%. 1%. 1 in 100 of our patients will get a re-herniation. So how do you minimize the risk of re-herniation? The answer is, number 1, behavior, patient behavior. So avoid heavy lifting. Do not lift anything over 40 pounds your first year, 40 pounds maximum, 20 kilos. The second thing you can do is wear a collar around your neck, a hard collar, which is what we tell our patients to do. We give them the hard collar. We want you to wear a hard collar for 6 weeks after your surgery. The first 6 weeks is the highest chance of reherniation. So we're going to put you in a hard collar for 6 weeks. That's what we do for everybody. Hard collar, 6 weeks. We tell people to wear it day and night. Day and night. Even when you're sleeping, you have to wear it. Okay? All right. Finally, no contact sports for the first year. All right? No contact sports. All right, so I'm trying to get over and get this last piece out. And it's a big piece. Oh, yeah. Right there. Look at that. Oh, yeah. It's not going to come out. Oh, look at it. Yeah, it moved out of the foramen. That was pushing on his nerve, on his left nerve root, C6 nerve root. This is probably the most important piece of the surgery. If I had to pick one herniation, this is it. See how he just cut it in third?
Yes, we do.
Come on, get the hell out of there. I'm chopping it down because it's too big to come out on its own. There it is. Oh yeah, come on. Get out of there. Any other questions?
Yes, we have a couple more questions. Next one from AAKK once more, asking, how long after surgery can a patient safely flex and rotate the neck past 45 degrees side to side?
Rotation is not a problem after surgery. I encourage people to start rotating their neck immediately after surgery. We encourage patients to walk, swinging their arms the same day, which rotates your neck, as you know. And but I tell them to do it in a collar. Wear a rigid collar. An Aspen collar is the best collar. Where'd you go, you little ghost? Huh. These pieces are having a difficulty coming out because they're so dense. They're heavy. They're weighted down with calcium. Okay, that's why I have to chop them up into tiny little pieces. Remember, what brings them up and out of the tube is hydrostatic pressure. That's the pressure of our irrigation system. If we don't have a strong irrigation system, they won't come out. You see the gold color? That's all calcium. Remember, calcium is a metal. Metals are heavy. And if you have calcium inside the scar tissue of the around the herniation, which these do, you see all the gold color, right? It doesn't want to float out. Even though it's small, it doesn't want to float out. There we go. Well, still. So I have to keep zapping it with the laser to make it smaller, 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 lighter, 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 more hydrodynamic. All right, we're just about done. Another minute on this disc, and we'll be done. Did I answer the question?
Yes. We have a few more.
Yeah, sure.
Next one from Charlie on YouTube.
Charlie, hi, welcome back.
Asking, viewing the lateral fluoro here on your YouTube, it appears that the cannula is quite large relative to the space.
Yeah.
Is that a function of optics? Is post-retraction annular wall integrity affected?
Yeah.
Thank you.
Yeah, great question. So it does look big on the lateral view because the tube is, remember, it's 4 millimeters. Now, 4 millimeters is about how tall the disc space is because remember, this is a degenerated disc. It's collapsed. A normal cervical disc space at C5-C6 would be a centimeter or 10 millimeters. This disc space is 4 millimeters because it's collapsed down, right? The disc is collapsed down. Therefore, the disc space is narrow. Therefore, on the lateral view, the tube looks like it's taking up the entire disc space, right? Which it is. It's taking up the entire disc space from top to bottom, but it is not taking up the entire disc space from side to side. So if you look at the AP view, you'll see that the tube is just a small part of the disc. But yes, that's a good observation. Good observation. All right, we're pretty much done with this disc. We're going to move on to 3-4, which is our last, third and final disc to fix. Great questions so far. We've had about 5 drops of blood. That's all. And the reason we're getting a little bit of bleeding right now is because, remember, what did I do here? I removed bone spurs. And bone spurs, well, they have what? They have bone marrow. Right? Bone spurs actually have bone marrow. And bone marrow is where red blood cells and white blood cells and platelets are made. So as I remove bone spurs, I'm exposing my surgical field and the middle of the tube to bone marrow, aka diploic bone, below the cortical spur. I'm removing the hard cortical surface of the bone spur, exposing the marrow, aka cancellous bone, and that's why we have a little bit of bleeding. But we've lost maybe 1 cc, maybe 20 drops of blood maximum. Not from the skin or soft tissues, but from the bone marrow. All right, I'm going to hold pressure for a moment, and then we're going to go up to C3-4. Jordan, show us C3-4. All right, you all see the disc at C3-4. Same problem, it's collapsed down, and it has a herniation in the back. Now look at 4-5. 4-5 is slipping. It's got an anterolisthesis of 4 on 5. 4 is slipping forward on 5. We're not treating this. Why? Because it's not causing symptoms. Okay, I'm sure of it. Otherwise, I'd recommend treating it. But he's going to have that anterolisthesis the rest of his life. He's not going to have symptoms. How's blood pressure? Good. Perfect. All right. Any other questions? There's the hole that we just did the whole surgery through. 4 millimeters. Show them. It's tiny. Okay. Looks like he got bitten by a 1-tooth vampire. So we got to fix that. We're going to have to do 2-tooth vampire.
Yes, we have a question coming from Rick on YouTube, asking, Dr. Deuk, if a person has adjacent segment disease, as I do, will I always have that problem?
Yes. Yes, you will always have that problem unless you come to Deuk Spine and let me fix it for you. Then you won't have that problem. Shot. Adjacent segment disease, my friend, is symptoms originating from, from the discs or joints above or below your treatment. So if you have adjacent segment disease, it means you're having symptoms from whatever radiographic findings there are. AP? In other words, lots of people have degenerative changes in the discs or facet joints above or below their fusion. However, they do not have symptoms. So the difference between adjacent segment degeneration, Sean, is that it? And adjacent segment disease is the people with disease, Sean, have symptoms. You understand? Symptoms. Symptoms is the key. Shot. All right. And shot. AP. Quick AP. Shot. By the way, I'm radiating my fingers here for the patient. Shot. It's one of the occupational hazards that I endure. Shot. All right, shot. Perfect. And I'm going to go in a little bit. Shot. Anchor. And I'm going to get an AP, see where we are. So basically I radiate my hands and my body and my staff's bodies and the patient to fix the patient. And it's not something I want or enjoy. Fine. But it's something we do. We do it because we want to fix our patients, and it's an occupational hazard nobody talks about. Shot. All right, right there. Shot. We're in like Flynn. Yeah, but we expose ourselves as doctors, spine surgeons, to radiation, and the effect of radiation is cumulative, meaning that over time it builds in our bodies and it never goes away, and it puts us at risk for cancer. And not just any cancer, some of the worst cancer in the world. Shot. We're at risk for osteosarcomas and chondrosarcomas and myosarcomas, which are incurable, horrific cancers that metastasize and kill people. So why do we do it? We do it because we want to help people. It's commitment, dedication to our patients and their well-being. But we also take our measures to reduce exposure to cumulative radiation by wearing lead, wearing thyroid shields, some people wear leaded glasses, I don't. And being responsible with the amount of radiation, trying to minimize the amount of radiation, as little as possible. So taking short bursts, using techniques, and having the best fluoro in the world at Deuk Spine, that's what we have, so we can actually reduce the amount of radiations our patient's getting, my staff's getting, and I'm getting, by having literally the top of the line fluoro. This fluoro machine, it's an x-ray machine. Normally an x-ray machine will cost you, around $50, $60, $80, $100,000. These are $180,000 each. And we invest in them because they're the best in the world. Siemens, German made. If you go to our website, you can see that. Shot, AP. I need some inline traction. Shot. All right, so that looks really good. We're right over the spinous process. Are you guys ready? Yep. A little inline. And let me see if I can advance. This is C3-4. Remember, we want to get to the back. Show us the herniation there, Jordan. Shot. You guys see the herniation right there. It's
yes,
outlined.
We do.
Yep. Very good. Everybody hold. And I'm going to advance our dilator. Shot. Perfect. You guys see how the disc space spread apart there? We're heading right for the tear, right for the herniation. This is the most beautiful, elegant spine surgery in the world. Endoscopic transdiscal was invented by the Koreans, the South Korean, Dr. Sang-ho Lee, Dr. Gun Choi. I was trained by them directly overseas. I brought it back to America, and I was literally one of 2 surgeons in the United States doing it. And then I added the laser to make it better. The other surgeon was in Florida as well, but apparently he's in jail. But for other reasons, not because of his surgery. Well, anyway, I won't get into it, but apparently he was using medical devices, implanting them in patients that were not FDA approved. So that's what happens when you do non-FDA approved surgery. He was literally putting metal in people's spines and charging the insurance companies for fusions and artificial discs and cages when he was making those things himself. It's very tempting for some doctors to cut corners and make more profit by finding cheaper ways, but at Deuk Spine we don't do that, and that's why we stay out of the crosshairs of regulators like the FDA, because we use everything that's FDA approved. Our competition will lie to you and say, a laser's not FDA approved. That's nonsense. It's completely FDA approved. And it's actually FDA approved for this exact surgery, for disc surgery. Shot? So we have that FDA approval letters, and when we fight the insurance companies to get them to pay, we always send them those approval letters. Just about finished. Surgery is going very well for this young man. We've got about another 15 minutes. We'll be done. I'll take your questions.
This next one is coming from AAKK once more on YouTube, asking, by what component of his physical exam were you able to determine C4 to C5 was asymptomatic, but the above/below levels needed treatment DLDR? Was it through nerve distribution pain or actual palpation?
Yeah, that's a great question. AKK, I assume you're a doctor. I think you're a doctor. Am I correct? So I'm actually teaching doctors right now, which is nice. But to answer your question, I look at each patient individually. I figure out what is bothering them. And in this patient, his biggest problem was radiculopathy, symptoms down his left arm. He had nothing really in the right arm. It was left arm. All he cared about is getting rid of those pain in his left arm. So I looked at the MRI and I saw that he had 3 discs that had herniations on the left side that were pinching the nerve root on the left side, the nerve roots. So that's why I chose these 3 discs. Now, there's a piece of herniation right there. See that? That was literally pushing on his nerve. It's too big to come out of the tube. I have to try to shrink it down. But that's what I do. I look at each patient. I listen to my patients. I tell my patients right up front, I cannot diagnose what's causing your symptoms without your help. You must tell me where your symptoms are. There's the herniation pushing on his nerve right there. It's too big to come out. Oh my gosh, look at that. It's jiggling around with the laser. Oh, there it is. We're going to try to grab it out. Okay? So I have to have my I don't look at MRIs and tell you what's wrong. Every MRI has things that's wrong structurally. But pain is a physiological phenomenon. It's not structural. It's physiological. And it has nothing to do with pinched nerves. It has to do with inflammation. So if you know where the inflammation is, you'll be able to target the patient's pain. Now, in his case, he had radiculopathy and he had radiculitis. He had both inflammation and compression of nerve roots going in his left arm. That's why I selected these discs to treat, because I felt if I treated these 3, we would get rid of 90 to 100% of his symptoms. And I believe I'm going to be right about that. We'll find out tomorrow. Any other questions?
Yes, we have a question coming from Charlie, once more on YouTube, asking, do you ever wish there was something less obtrusive than a C-arm available? I've seen often how it rotates to lateral, the opposite end swings out from under the table, almost hitting surgeons.
Yeah. You're right, Charlie. You are 100% right. It would be lovely if there was a way to navigate and localize to the back of the disc. By the way, this is a bone spur in the foramen on the left side at C3-4. That is all bone spur right there. You see that? And I'm removing it with the laser. And it's literally sitting on top of his nerve, his left C4 nerve root. Now the C4 nerve root, if you know the dermatomal distribution, it actually goes into the shoulder. Not down the arm, but it goes into the shoulder. And he has pain in his left shoulder. And this thing is literally pinching his nerve right there. I just unpinched the nerve. You guys see that? So there was definitely some herniation too. We saw that earlier, just a few seconds ago. But this bone spur is digging into his nerve right there. And this, I'm literally removing. Remember, the laser glass fiber is 1/2 of a millimeter. And we're literally removing 1/10 of a millimeter to 1/20th of a millimeter of the herniation right off his nerve root right there. No other surgeon in the world can do this. And you can't do it without the laser, okay? You must do endoscopic. You must do endoscopic transdiscal. You must use a laser. So anybody not using a laser, anybody not doing endoscopic with this degree of visualization, quality of magnification, and optics is doing less than the best for the patients. So in my opinion, every other spine surgeon should be referring their patients to us. around the world saying to their patient, if you want the best, you need to go to Deuk Spine Institute. That's the moral and ethical thing to do. When I see a patient with a brain tumor, I don't tell them, I'll take your brain tumor out because I need the money. I tell them, I am not the right doctor to remove your brain tumor. I used to be. I used to take brain tumors out many years ago, but I stopped doing it. And my specialty is now spine. So the right thing to do is to refer your patients to a doctor who can do the best surgery for your patient. If your patient can't afford to go, then you need to do your best to treat them. But you should give everybody the opportunity to go. Not everybody can afford it, but for those that can, they should have the opportunity. You shouldn't be lying to patients and telling them, you offer the best treatment, ACDF, you offer the best treatment, artificial disc, you offer the best treatment, laminectomy, when you don't. All right. Any other questions?
No current questions, so we do have a comment from AAKK once more on YouTube saying...
There's another piece of herniation. Go ahead.
Saying thank you, Dr. Deuk, and yes, I am also a physician and appreciate all of your help in understanding your surgical technique. Your teaching should be a required rotation for all medical students and residents.
I 100% agree with you, AAKK. I agree, because too many doctors are taught that neck and back pain are not fixable, not curable, and they're telling patients this information when it's not true. And it's sad. It's sad because patients believe them, and the patients end up suffering needlessly when they should not be suffering. Just about done. I have about 5 minutes left on this disc, and I'm just still removing this bone spur. You can see how I use a combination of the optics with the laser to remove the bone spurs. He has a lot of bone spurs, more than most patients. He has a lot of scar tissue. Right here is scar tissue. All right, and I move. You guys see how I approach. I don't just come straight down, because you can harm the patient if you do that. You have to move in circles usually, and you have to always be watching what you're doing to make sure that you're not going too deep. You guys see that? That is the spinal cord right there. That is the dura of the spinal cord. And I do not want to go and damage that. That will be very, 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 very bad for the patient, and I would not feel good about myself as a surgeon. But that is what I'm avoiding, is that spinal cord. But you can see it has a very different appearance, and it has a very specific location, and the herniation went right through the annulus right there and the posterior ligament, and I've just gotten through removing a lot of it, and I'm going to take a little bit more out, and that's going to decompress, but you see all the scar tissue too. So spinal cord right there, and herniation right on top of it, removing with the laser. This is literally the future of spine surgery. But we do it today at Deuk Spine. It's the future for other doctors. And many of them will never get the opportunity to do this surgery. And I will tell you, I am facing a backlash from my colleagues who are neurosurgeons, who don't know how to do this surgery, and they realize that we've had 0 complications surgically, and the patients are doing so well. We have over 400 testimonials, video testimonials of real patients that we've cured. We have thousands of patients we've cured, but we didn't do testimonials on all of them because it's expensive for us to do that. And so the ones we've done, we have 400 plus now testimonials, and my colleagues are angry because they don't know how to do this treatment, and because they know it works, and they feel guilty that they are doing fusions and artificial disc surgery on patients, and they don't know how to do this treatment. And these are the best trained neurosurgeons in America. They're in the highest positions academically in America and the world probably. And they are targeting me to try to shut me up and not teach you guys about what's available here in the world and force you guys, you the patients, to have fusions and artificial discs and laminectomies, just horrible surgeries that are dangerous. They want you guys to do that, not have an option. They don't like me because I'm offering patients better treatment than what they are. And we have 5 minutes. I'm almost done. Guys, these are all pieces of herniation. Our next patient, by the way, is lumbar, correct? He's coming from Kuwait. He's a very smart man. He's here with his lovely wife and daughter. She wants to be a doctor. And we're going to have him back here shortly to do his surgery. Okay? By the way, people ask me, Dr. Deuk, I have some medical issues, diabetes, high blood pressure. Can I still have your surgery? The answer is yes. The reason you can have our surgery is, number one, it's so minimally invasive. And number two, was that you? I could feel his pharyngeal constrictors hit my hand. How funny. Yeah, he's definitely got twitches back. He's ready for extubation. Just about done, about another minute left. Henry, why don't you, if there's no questions, show our audience why our surgery, the Deuk laser disc repair, is better than ACDF, laminectomy, foraminotomy, artificial disc, everything else available out there.
We do have 2 questions.
All right, I'll take them. Actually, you know what? Save the questions. I'm going to come and talk to my audience. I'm going to come to you guys and I'm going to see you face to face. It's been a while since we've done that. But I will tell you, before Henry starts this video, we are done. This is the last foramen that I'm decompressing. There's nothing there. You can see everything has been treated, maybe a piece right there. And I will come and answer your questions. So folks, type up your questions and we're going to do a face-to-face. I'm Dr. Deuk Majin, CEO and founder of the Deuk Spine Institute. I'm here to talk to you today about neck pain and its common treatments. Neck pain has different causes. The most common cause of neck pain is a herniated disc. Herniated discs account for about 85% of chronic neck pain. The second most common cause of neck pain that's chronic is the facet joints. There are facet joints on both sides of the spine, left and right. There is one facet joint for every disc. Facet joint pain requires a different kind of treatment targeted at the facet joint itself. For disc pain, which accounts for 85% of neck pain, the best treatment in the world is the Deuk laser disc repair. It is the most advanced treatment that is the safest and has the highest chance of successfully eliminating symptoms. Let's talk for a moment about what's important for patients who are considering treatment for neck pain coming from an injured or damaged disc in their spine. The most important thing for patients, number one, is getting rid of their symptoms. The type of symptoms that disc herniations or disc injuries can cause include neck pain, headaches, and symptoms down the arm, such as weakness, numbness, tingling, or even pain shooting from the neck down into the arm. The symptoms of neck pain include disc herniations, which are the most common cause, and patients want those symptoms gone. That is their number one priority and goal. The second most important goal for most patients is to avoid a complication from the treatment. Medical treatments do have complications, and the more invasive the treatment, the more likely a complication will occur. Complications from surgery, for example, can include blood clots, pneumonia, heart attack, infection, failure of the spine to heal properly after surgery. There can be implant migration or implant failure, adjacent segment disease, and vascular complications such as injury to the blood vessels or nerves in the neck, including the trachea and esophagus. Nobody wants a complication from spine surgery on their neck, so less invasive is typically going to be a better option to avoid those complications. The third thing patients really want when they're looking at treatment options for curing their neck pain is they want a quick recovery. People want to get back to a normal life as quickly as possible. They want to go back to their activities, they want to be active, they want to play sports, and they want to go back to work. And finally, the next thing to consider is long-term results. For example, if you have a treatment today and it works, how long will that treatment last, and will it create additional problems down the road for you? Treatments like spinal fusion that are invasive typically result in the need for additional treatments such as pain management, physical therapy, and possibly additional surgery. We're going to look at each of these individually and go through each of these options individually. So we're going to start with more invasive treatments that are typically recommended for patients with herniated discs or degenerated discs in their neck. The most common treatment recommended around the world is anterior cervical discectomy and fusion. That is a surgical treatment where the entire disc is removed surgically through a large incision that is very risky. There's bleeding associated and risk of injury to surrounding structures such as the esophagus, trachea, and blood vessels in your neck. Complications are very common with this type of surgery. The complication rate is accepted at 48%, which is a very high number. So if you're considering ACDF or anterior cervical decompression and fusion, you are looking at a very high complication rate. The success rate of this surgery at eliminating neck pain is very low. It's somewhere on the order of 25%. That is the generally accepted success rate at eliminating neck pain. An additional treatment that you can consider is artificial discs. Artificial discs are very similar to ACDF. The difference is instead of fusing two bones together with a metal plate and a cage, we're actually putting in a mobile disc made out of metal and plastic that moves. The problem with the movement is that these discs do pop out of the disc space. Over time, they can fail. They can cause collapse of the vertebral body above and below through fracturing, especially in patients with weak bones such as osteopenia or osteoporosis. Those types of patients are at high risk for complications from both ACDF and artificial discs. Another complication from artificial discs is that you can develop facet joint pain and adjacent segment disease. Very common with artificial discs and fusion, and they typically have the same rate of adjacent segment disease. There's also a long recovery associated with both ACDF and artificial discs. Recovery can take months to years, if recovery even happens at all. There's tremendous scarring in the wound associated with ACDF and artificial discs. Lots of scar tissue, lots of pain, and lots of problems after these surgeries that are invasive. Alternative treatment would be to go in the back of the neck and do a cervical laminectomy and fusion. Again, large incision, high chance of complications, very long recovery, taking years to recover. All three of these types of surgeries, ACDF, artificial discs, and posterior cervical laminectomy and fusion, require the use of postoperative narcotic painkillers. Narcotic painkillers are opioids. They are dangerous. People get addicted to them, they can be abused, and people can overdose. It's easy to overdose on narcotics because you want to keep taking them to treat the severe pain you're going to have after these invasive type surgeries. The severe pain can last weeks or even months, and the addiction can happen very quickly. Let's move into less invasive treatments such as epidural steroid injections. This is a treatment commonly recommended by pain management doctors. They stick a needle into your spine and inject the steroid medicine to reduce inflammation. While this treatment can be effective at temporarily giving you relief for a few days or even a few weeks, the pain always comes back from a herniated disc because the source of pain is never being treated. The annular tear and inflammation within the annular tear is not treated by an epidural steroid injection. The steroid goes throughout your body and causes systemic side effects such as high blood pressure, elevated blood sugar. In patients with diabetes, this could put your sugar up into the 300s and 400s, which is very dangerous for patients. So steroids should be avoided as much as possible. Next, let's turn to spinal cord stimulators. The problem with spinal cord stimulators is they are highly invasive and they are frequently put into patients by untrained doctors who are not surgeons. These doctors are typically pain management specialists, and they're putting these stimulators in patients not because they can cure your pain, but because it's another treatment that they have up their sleeves. These treatments with stimulators pay these doctors obscene amounts of money. The profit for the doctor can be in the tens of thousands of dollars. Avoid spinal cord stimulators. They do not work, they're dangerous, they put you at tremendous risk, and in the end, basically you're taking this device, sticking it on top of your spinal cord and putting a pacemaker under your skin that you're gonna have to live with for the rest of your life. They cause scar tissue and they frequently migrate and get out of position. Next, we're going to talk about physical therapy. While physical therapy has many benefits, such as keeping you toned and fit while you're struggling through the pain and trying to stay mobile, but physical therapy will never, ever cure pain in the neck from a herniated disc. It will just try to keep you active and from getting more and more sedentary and developing deconditioning of your muscles because you're sitting around because you have neck pain all the time. Finally, let's talk about the Deuk laser disc repair. The Deuk laser disc repair is the solution for neck pain. If you have a herniated, bulging disc, extruded, ruptured disc, protruded disc, or degenerated disc, the Deuk laser disc repair works by minimally invasive treatment going to the back of the disc where the problem is coming from. This is the tear in the back of the disc that has inflammation, and using a laser that is extremely precise. The laser fiber itself is 0.5 millimeter or half a millimeter wide, and the endoscope allows me to see 1/20th of a millimeter. I can directly see the nerves and spinal cord. It is an extremely safe treatment. As far as results go, the Deuk laser disc repair has the highest success rate of all the treatments we've discussed so far. We have a 99% cure rate of neck pain coming from herniated discs, and the Deuk laser disc repair has 0 surgical complications to date. Our patients have an immediate recovery. In 1 hour, they're leaving our facility and they're going back to their hotel room. They usually drive themselves in the next morning for a quick checkup, and then it's back to a normal life. Well, I've enjoyed talking to you, and thanks for taking the time to listen to our video. I'm Dr. Ara Deuk-Machen. We'll also find this on our podcast at Deuk Spine Institute Podcast. Thank you. Hello there, I'm Dr. Deuk-Machen. I've just completed a 3-disc repair in the neck on a patient who traveled here to Deuk Spine Institute from Puerto Rico. And he came here with his lovely girlfriend because he did not want to have fusion done. That's all his surgeons were offering. ACDF, artificial disc fusion. He did not want it. They offered laminectomy. He said, nope, I don't want it. Laminectomy, I don't want fusion. And he found the Deuk Spine Institute online. He realized that what we are offering with the endoscopic laser surgery is far better than any laminectomy in the neck or any fusion or artificial disc. Less bleeding, faster recovery, immediate recovery in 1 day, and you can go back to your work within 1 or 2 days and back to a normal life. Plus, we have a great success rate. We have the highest success rate out there with any surgery on the neck. Now, if you look back at the surgery we did, this patient had a combination of herniated disc, scar tissue, calcium deposits, and bone spurs, and inflammation, all pushing on the spinal cord and nerves. And we looked at each of those 3 discs with the endoscope. We cleaned out all the herniations in the back. We decompressed the spinal cord and nerve roots like we're supposed to. And we did it all without fusion, without an open incision, or without any implants. It's done naturally. And that's what he came here for. We were successful in finishing the surgery. He'll be waking up and basically going home in the next hour. Amazing. No pain meds, no bleeding, no hospital, all outpatient. Only available here at Deuk Spine Institute. We have some questions,
Yeah.
I understand, Henry, so let's take the questions.
That we do. This next question coming from Charlie, once more on YouTube.
Hi, Charlie on YouTube. Thanks for joining us today.
Asking, this might be silly, but would it be advantageous to have a patient oriented vertically for spine surgery rather than horizontal on the table?
Well, Charlie, that's an interesting question. Charlie's asking, Dr. Deuk, instead of having your patient lay on their back looking up at the ceiling, what about putting them in a sitting position and doing the surgery that way? I think you'd run into an issue with their body wanting to slump forward once you relax them and they're asleep. They would just basically fall forward. So we'd have to take their head up. From a fluoro standpoint, the fluoroscopy unit would then get in the way of the anesthesiologist, who's always at the head of the bed. And being sitting up increases the risk of air embolism air venous embolism. I don't think it would be significantly that much increased over the DLDR with recumbent, but I think it poses some new challenges. Long story short, here's my philosophy. If it ain't broke, don't fix it. It's an old saying. It's been around in America for over 100 years. If it ain't broke, don't fix it. What it means is if what you're doing is working and you're not having any problems and you're having the best results out there, don't change it. All right? Don't change it. Because once you start changing variables, you can end up with a bad result. We have in 20 years, now we've done 2,720 Deuk laser disc repair. We have never had a surgical complication, not one. Our patients do fantastic. We have no bleeding. We have no problems. So I don't want to change that because it's already really good. The company that made our endoscope, Wolf, out of Germany, they approached me 15 years ago. They said, we are going to stop making the cervical scope you're using. We want you to buy the new scope. And I said, why? The one I'm using for the last 5 years, it works perfect. And the results are perfect. Why would I want to go with the new scope that's bigger, has a bigger tube? I like the 4 millimeter. I didn't want the 5.5 millimeter tube. Yes, it's got rod lens configuration, which is better optics than fiber optic visualization. However, it's more likely to break and it's also bigger. So it's going to have a bigger incision and bigger pass through the disc. So I said no. And I've stuck with the same scope for 20 years, the same equipment. It's amazing. It works. Don't change it.
And then lastly, from AAKK, once more on YouTube, asking, in your opinion, Dr. Deuk, how far out are we from having this procedure adopted by insurance companies and integrated into practice to stop unnecessary surgeries?
AAKK is asking, Dr. Deuk, how long till the insurance companies cover this surgery completely and we can stop doing unnecessary invasive surgery like ACDF, which is anterior cervical discectomy and fusion, artificial disc surgeries, laminectomies, and discectomies? I don't know. It's a great question. I think it could happen suddenly if we have our government get involved. If our government, the United States government, and Trump, or Elon Musk, or Kennedy, RFK, Robert Kennedy, if any of them become aware of this surgery, which they're not aware of it right now, most likely, and they understand what we're doing and why we're doing it, they will 100% adopt it. There's no doubt. It's a no-brainer. We call it a no-brainer. It's not like it's equal to what's being done now. It's leagues beyond and better for the patient and the economy than ACDF, laminectomy, microdiscectomy, foraminotomy, epidural injection, spinal cord stimulator, medial branch block, RFA. I mean, the list goes on, right? There's no end to the number of treatments that doctors have created for neck pain, for herniated disc, for radiculopathy and stenosis. There's tons of treatments out there, but they don't work. And they're terrible. They're very invasive and dangerous. This surgery works. It works the best of all of them, in my opinion. And if Trump or these influencers knew about it, they would adopt it immediately and force the insurance companies to cover it. Otherwise, it's going to be a long process of legal battles, litigation, court battles, lawsuits between my patients and their insurance carriers. And the insurance companies have written the laws that we have to obey that make it almost impossible for us to defeat them in court because they've written the laws of ERISA to basically allow them to deny treatment to patients, even though the treatment is medically necessary. And there have been cases in the last few years that patients have sued their insurance company for not covering medically necessary treatments, and the court decided the insurance didn't have to pay for it because insurance doesn't have to pay for medically necessary treatment. It's crazy what's happening. And this is all thanks to our politicians in Washington, D.C., and our state politicians in each state. These are lawmakers. They're your state senators, your state congressmen. They are some of the worst people in the world because they write laws that allow insurance companies to kill patients. And that's really what's happened. When people can't get this care, they're forced to do invasive surgeries. They die from invasive surgeries. You know, lots of people die from invasive spine surgery. And it's not because the surgery is bad, it's because the surgeons are bad. I mean, I hate to say it, but I've done invasive spine surgery for years, 30 years. I don't have patients dying from it. I've never had a patient die from it. But these other doctors, surgeons, have lots of patients being hurt by their surgeries. And it's all okay. And the insurance companies are fine with it because the more patients today that get hurt from invasive spine surgery, like laminectomy or fusion or artificial disc, the more those people go out on the internet and squawk about it. They talk about how bad, how they're paralyzed and how miserable their life is. They're highly visible stories. And everybody watches those stories and everyone says, I don't want a fusion. I don't want a laminectomy. And guess what? Who benefits? The insurance companies benefit. Because you, the patient, are refusing medical treatment that you need. And it's not the best medical treatment. The best is here at Deuk Spine, in my opinion. But you are refusing medical treatment nonetheless. Therefore, you're saving the insurance company's money. Okay? Anytime you refuse a doctor-ordered treatment, prescription, test, the insurance company is saving money. And they're becoming more profitable. They love it when there are bad outcomes. The insurance company loves it when patients have bad outcomes because bad outcomes are good for their bottom line. Not you, but good for the insurance company's bottom line. All right, any other questions?
Yes. So last one from Charlie, once more on YouTube, asking, I saw a video about biologic intradisc injections. What is this all about?
Thanks, Charlie. Yeah, there are biologic intradiscal injections. What is it all about is the question. Okay, intradiscal injections don't work. They've been trying them for over 50 years. And the problem is anything you inject into the disc eventually gets metabolized or removed by your body, or it squeezes out through the tears around the disc. They just don't work, period. And they don't fix the source of the problem, which is what I fixed with laser, the annular tear and herniation. There's only one treatment in the world that gets rid of the herniation and cleans the annular tear to fix your disc naturally, and that is the Deuk laser disc repair. There's nothing else. I'm aware of every other treatment, and they don't work. They just don't work. Now, who does biological injection in the disc? Who does it help? It doesn't help the patient. It doesn't help the insurance company. It helps the doctor who does it. He makes money. She makes money. It helps the hospitals make money, or the surgery centers. And it helps the people on Wall Street make money because they're the ones investing in these nonsense treatments. So they're scamming you, the patient. You're the recipient of this garbage treatment that doesn't work, that could hurt you. And the people making the money just follow the path, follow the money. You'll find out who it's benefiting. It's not benefiting the patients. Doesn't work.
That is it for questions.
All right. Thanks for joining us. We'll be back shortly with our next patient, who is from the country of Kuwait. And he found us on the internet. He did a telemedicine for free. And he's now here to get his back fixed and his neck fixed. We're going to be fixing his lower back today, hopefully, and we're going to fix his neck on Thursday. I will tell you, in all transparency, that he does have an issue with his heart, and we're going to be watching his heart very carefully during the surgery. But I don't think anyone in the world would operate on him besides us. Why? Because he is a higher risk patient from a cardiac standpoint. He did get clearance, and we are going to do his surgery. But one of the reasons he chose Deuk Spine Institute is because our treatments are gentle on the heart. and people with heart problems can do our surgeries because we're not doing general, anesthesia where the patient is bleeding from the spine surgery like invasive surgery. He was offered laminectomy infusion over in Kuwait, Saudi Arabia. He has the means to go anywhere in the world he wants. So he chose Deuk Spine because the minimally invasive nature, the fact that our procedures are the most successful at curing symptoms, and the very fast recovery and low strain on the heart. So that's why he's here. We'll be doing his surgery next. We're doing 3 discs, hopefully, and the facets on both sides and both piriformis muscles. So we're going to do all that on this gentleman from Kuwait. And after him, our patient from South Africa. He traveled to Florida for Deuk laser disc repair on the thoracic spine. He has 5 discs in this thoracic spine that are damaged, but we figured out that 2 of them are probably causing 80% of his pain, and I'm going to try to fix those 2 today. And then after him, we have a patient from Kentucky who has facet pain in the neck. We're going to do the Deuk plasma rhizotomy to kill the pain nerves in the neck.